Picture this. You're working in the emergency department when EMS bursts through the doors with a patient who was found unresponsive. You look at the monitor. Oxygen saturation is falling. You look at the patient. They're barely breathing. Then you look at the eyes. Pinpoint pupils. And just like that, your differential diagnosis gets a whole lot shorter. This is one of those classic medical patterns that should almost make a neon sign flash in your head. Unresponsive, respiratory depression. Pinpoint pupils. When those three clues show up together, opioid overdose should immediately move to the top of your list. And here's the first big teaching point. The opioid itself is not the thing that's killing the patient. The lack of breathing is. Think of opioids as someone walking over to the body's respiratory thermostat and turning it all the way down. The brain stem stops caring about carbon dioxide. Breaths become slower, then shallower, then fewer. Eventually, the body starts running out of oxygen, while carbon dioxide quietly piles up in the background. It's like watching a car sit in a closed garage with the engine running. The danger isn't the car, the danger is what happens to the air. That's why airway and breathing become the entire game at the beginning. Before you're thinking about exotic laboratory tests or toxicology panels, you're thinking, can this patient breathe? Can they protect their airway? Do they need immediate intervention? So, oxygen goes on. Continuous pulse oximetry begins. Intravenous access is established, continuous cardiac monitoring starts. An electrocardiogram is obtained early. But here's where many learners get fooled. Medicine often teaches us to gather data before acting. Opioid overdose is one of the situations where the patient gives you permission to act first. If someone is unresponsive, breathing slowly, and has pinpoint pupils, don't stand around waiting for lab confirmation, like you're waiting for a jury verdict. Give naloxone. Immediately. Naloxone is the bouncer that kicks opioids off the receptor. The opioids are partying inside the receptor. Naloxone walks in, throws them out, and says, "Party's over." And sometimes the response is dramatic. The patient who looked nearly lifeless suddenly opens their eyes and starts talking. It's one of the most satisfying moments in medicine. But don't get too comfortable, because here's the trap. Naloxone is often the shorter movie. The opioid may be the longer movie. Imagine kicking a guest out of your house, but they still have a key and are waiting outside. Once naloxone wears off, the opioid can come right back and reclaim the receptor. The patient who looked great 15 minutes ago may become sleepy again. Then, somnolent. Then, hypoventilate again. That's why repeated reassessment is so important. This is not a one-and-done diagnosis. You keep checking respiratory rate. You keep checking oxygenation. You keep checking mental status. You keep asking yourself, are they staying awake? Or are they drifting backward? Now, let's talk about the workup. A common mistake is assuming that because you figured out the diagnosis, the evaluation is finished. Not even close. You still need to understand what happened and whether anything else is hiding underneath the surface. Think of overdose patients like mystery novels. Sometimes there is one culprit, sometimes there are three. So, you check a finger stick glucose because severe hypoglycemia can also make someone unresponsive. You obtain a complete blood count and a comprehensive metabolic panel. An arterial blood gas helps you understand how much respiratory failure has occurred. Lactate can provide clues about tissue hypoperfusion. Creatine kinase becomes important if the patient has been down for a prolonged period. Because here's another mental image. Imagine lying unconscious on a hard floor for hours. Muscle tissue does not enjoy that experience. The result can be rhabdomyolysis, and that's something you don't want to miss. The toxicology evaluation is equally important. Mixed overdoses are common. Patients don't always read the textbook before arriving at the emergency department. Alcohol may be involved. Acetaminophen may be involved. Salicylates may be involved. Or tricyclic antidepressants may be involved. So, you cast a wider net. If the story doesn't quite add up, consider carbon monoxide or methemoglobin testing as well. Urinalysis should be obtained. And in female patients, a beta-HCG test should be included as part of the evaluation. The diagnosis becomes even clearer when you remember that opioid overdose is rarely managed with naloxone alone. Supportive care remains critical. Continue oxygen therapy. Administer intravenous fluids when appropriate. Maintain close monitoring. Be prepared to repeat naloxone if respiratory depression returns. Let's pause for a moment and talk about activated charcoal, because this is an area where mistakes happen. Here's the simple rule. Activated charcoal only belongs in patients who can protect their airway. If the patient is awake and the ingestion was recent, particularly within the last couple of hours, activated charcoal may be helpful. But if they're sedated and unable to protect their airway, activated charcoal becomes a bad idea very quickly. Think about handing a cup of black powder to someone who is barely conscious. What could possibly go wrong? Aspiration. And now, you've taken a toxicology emergency and added a pulmonary emergency on top of it. Not ideal. As treatment continues, remember that the monitor doesn't tell the whole story. The patient tells the story. Is the respiratory rate improving? Is mental status normalizing? Are oxygen requirements decreasing? These trends often matter more than a single laboratory value. One snapshot can fool you. A movie tells the truth. And overdose patients are movies, not snapshots. Because recurrent respiratory depression can happen unexpectedly, many patients require intensive care unit monitoring. You need a setting where deterioration is recognized immediately and treated immediately. Once the patient is medically stable, zoom out and ask the bigger questions. Was this accidental? Was this intentional? Is there an underlying substance use disorder? Does the patient need psychiatric evaluation? Because treating the overdose is only half the job. Preventing the next overdose is the other half. Before we finish, let's lock in the major pitfalls. Never wait for laboratory confirmation before giving naloxone. Never forget oxygenation and airway support. Never forget that mixed overdoses are common. And never assume the patient is safe simply because they improved once. The opioid may still be waiting in the wings. If you remember one thing, remember this. An unresponsive patient with pinpoint pupils and respiratory depression should make you think. Naloxone now, airway support immediately, and close monitoring afterward. Recognize the pattern, and you'll save lives. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.